guys, how are you? I see a lot of familiar faces. We wanted to, Dr. Rudolph and myself wanted to kind of get to out to the public a little bit and talk to you a little bit about some different pathologies and talk a little about some of the treatments that we see in the office most common, and some of the ways we treat them both conservatively and sometimes in the more aggressive side. And you can go ahead and when you think about some of the most common things that we think about, arthritis of the foot and ankle is the most common thing that we probably get asked questions about the most. And arthritis, whether it's your shoulder, your knee, or your hip, or your foot and ankle, is certainly very common. With the wear and tear that we put on our feet and the amount of walking and standing and activity that we do, both with social activities and with work, the wear and tear on those bones and joints is something that there's certainly a lot of misconceptions about. And it's also something that there are a lot of options for, both somewhat easy and comfortable options, and sometimes, when necessary, a little bit more aggressive options. But there are options out there for people who do suffer from arthritis of the foot and ankle. A little bit about my background. I've been with Coordinated Health now for, I believe, 6.5 years, and this is home base for me. This is kind of where my practice is based out of. But I do work out of our Stroudsburg, Broadheadsville, Easton, Allentown, and Bethlehem clinics. So we kind of run around a fair amount throughout the week, and my specialty is foot and ankle surgery. I'm board certified not only in foot surgery but in reconstructive foot and ankle surgery as well. So it's what I treat all day long. It's something that every patient that I see throughout the day is something that's related to foot and ankle. So with that being said, there are two main types of arthritis. If you want to create a blanket category for them, there's primary osteoarthritis, and then there's secondary osteoarthritis. And in the foot and ankle, we've got osteoarthritis that encompasses both of those subject groups. The first type of osteoarthritis, which is primary osteoarthritis, is where you get a wear and tear to your joints, basically from an overuse situation. And when we think about osteoarthritis, we think about a joint space that hypothetically, say, would be this wide. Then that joint space over time shrinks and narrows so that the bones become much closer together. They grind and irritate a little bit. The cartilage surfaces become a little bit eroded. You lose that viscous motor oil type joint fluid in the joint cavities themselves, and it creates a situation where we've got pain and limited motion, and ultimately discomfort in the foot and ankle, and certainly in the knee and the hip, difficulty ambulating. So those are things that we see in primary osteoarthritis because of different things like hereditary factors, genetic factors. When researchers have looked at the amount of protein molecules that sit in our cartilage, and all of us may have different levels of that, and that can kind of predispose you to developing a type of primary osteoarthritis, whether it be in your big toe joint or your ankle, middle of your foot, or your hip and knee. The second type of osteoarthritis is secondary, and this is something that we see in the ankle, and even sometimes in the great toe a lot, which is from trauma, some sort of traumatic event. And I see some faces here in the audience that have had traumatic events to their foot and ankle and have developed, in some situations where they've developed that arthritis from that traumatic event. And the most common thing that you think of is the foot and ankle injury, where the ankle's broken. When you break your ankle, you dislocate and you fracture that cartilage surface. When you put it back together, even when we do our best job ever putting it back together, once that cartilage has been damaged, that cartilage is damaged forever. Nature's given us one set of cartilage in our life, and once that is eroded away, or once that has been damaged, we have to do other things to help supplement that. But there's no way we can get that primary cartilage back. And so when you have an injury like a traumatic event of an ankle fracture, or you drop something on your big toe joint, like people working with cinder blocks and things of that nature, those things can create a situation where that joint will break down over time, and you go from a joint that's got great range of motion, and over a period of time you'll lose your range of motion. You'll start to notice some bone spurs are forming. You'll start to hear some cracking and popping. You'll notice that when you get up in the morning, it takes you a little bit longer to get things loosened up, and as you get going, you're good. But the minute you stop and slow down again, you got to get revved back up again. And these are the things that are classic for arthritis throughout the body. Diabetes is something that we also think about that can create an arthritic situation, so to speak. And this is really a topic for a whole other day, because you could spend several hours just talking about the basics of how the diabetic, how you're controlling your blood sugar can affect your legs and extremities associated with that diabetic patient. But it can create a situation where the foot can lose its ability to maintain its foot structure, and it is, by definition, a secondary type of arthritis. And then the third thing that we see is somebody's got a little bit of uncontrolled gout. This is a situation where you've got a uric acid level that's too high in your body. You're eating a food that's causing the inability for your body to metabolize something called a purine. And there are a lot of healthy foods that have that are very high in purines, and there are a lot of unhealthy foods that are high in purines. And it's certainly a myth that people think that if you have gout, you're eating unhealthy. Well, you can have asparagus and broccoli and one glass of red wine, and between all three of those foods, which are not necessarily unhealthy for you in moderation, you can have a gout situation. And when gout builds up in your, when the uric acid level builds up in your joint, for whatever reason, it tends to deposit itself most commonly on the great toe, very commonly on the ankle, sometimes around the knee, and sometimes around the elbow. And those are, and also some of the other joints too. I mean, there's certainly, it's not necessarily set to those joints, but those are the joints we most commonly see. And what will happen is when that uric acid is sitting on that joint for a period of time, it acts like a termite. And it'll actually eat into the joint, and it'll actually start to erode that joint, and it'll create a situation where you develop a secondary type of osteoarthritis. So there are a plethora of ways that our foot and ankle can become arthritic. And again, you think of the two most common that we see is one, we've got that family predisposition to developing that primary OA, and number two, we've got that ankle fracture, or we've got that injury to the foot and ankle, which has caused a nice healthy joint to break down over time. So those are the two most common ways. What I like to do is kind of break down the foot and ankle very quickly into three different sections: the forefoot, the midfoot and heel, and then the ankle, and talk to you a little bit about how arthritis can affect very, very generally those three parts of the foot and ankle, and talk to you a little bit about what we can do to help in a very generalized way to treat some of these problems. And then if you guys have any questions, we can certainly answer them, and if you want us to take a look at anything upstairs, we can certainly do that for you on a general basis. So again, when you think about the forefoot is this area here, which is basically the ball of the foot and the toes. And the most common spot that gets arthritic in the ball of the foot and the toes is the big toe joint. The great toe joint, called the first metatarsal phalangeal joint, is the second most common joint in the body to get arthritic behind the knee. And the reason is because of all the body weight that goes through our big toe when we're stepping forward and we're doing activities like walking or running. The midfoot is broken up into the area just in front of the ankle to the base of the metatarsal area, the exactly what it is, the middle portion of the foot. And then the heel and the ankle are obviously, your heel and your ankle. So, but those three areas are each affected very, very differently when you think about how arthritis can affect, your ability to ambulate and what we can do to treat it. So forefoot arthritis, again, when we think about our big toe joint, we think about and we also think about our toes. There are a couple situations where we have to take, the ability of what we're wearing, what we're doing, how we're doing it, and what kind of events have happened to us. We have to take that into account when we understand how your arthritis was formed. Again, the big toe joint, 2.5 times body weight goes through your big toe when you walk. Many more ground reactive force goes through that when you're running. So when you think about every step you've taken over your lifetime and think about how much ground reactive force is going through that joint, that little joint is taking a lot of pressure over the course of a very, very basic day. And then you couple that with maybe an injury here or there, it creates a situation that can certainly predispose you to arthritis. And what will happen is this big toe joint will lose the width of its joint. You'll start to develop some spurs on the top of your joint. You'll notice that sometimes the toe will actually angle, and you also not only have arthritis, but some sort of bunion deformity associated with that. And what will happen is you need to have 45 to 50 degrees of motion of your toe going up to have a successful gait, for you to be able to push off the proper way. And when that toe joint starts to become arthritic, you're unable to push off of that toe any longer, and you get this force that actually goes between the bones instead of through the bones. And what will happen is it starts to create friction and grind. And that grinding is what causes the bone spurs to form. That's what, again, causes the cartilage to erode, and that's what causes the motion to become much more limited. That causes us to walk a little bit differently, causes knee, hip, back, pain. It's one big revolving door of discomfort that all comes from this little joint that's maybe about 4 or 5 square centimeters in diameter, and it creates a very, very painful situation. Now, with that being said, the toes are another thing that you look at, because oftentimes when you develop arthritis in your great toe joint, or if you have a bunion that creates an arthritic joint, your toes will then become also affected, because the ligament and tendon pull on the intrinsic musculature of the foot is altered. And what will happen is your toes start to contract a little bit, And as they start to contract, they become a little bit more rigid with time, and you develop a situation where you develop something called a hammer toe. In the beginning, your hammer toe can be very reducible, meaning you can straighten the toe out. But if you have a hammer toe for many, many years, those toes become so contracted, you can try to grab them and they won't straighten at all. They become very, very rigid, almost clawed. And again, it's a situation where it's all related to the biomechanics of how our body's working and some of the events that happen throughout our lifetime that help predispose you to getting these types of situations. Go ahead. Sure, go ahead. Sure. Mm-hmm. Gout, again, gout is when you... Okay. So gout is a situation, again, where you develop uric acid, you have a uric acid level that's way too high in your body. And that occurs because your body cannot metabolize a chemical structure called purine. And when you can't metabolize that purine, it gets converted to uric acid. The uric acid crystals tend to deposit themselves in the foot and ankle. So what will happen is that uric acid will sit on that joint and will eat away at that joint, like a little termite in wood. And when that happens is the joint's no longer able to function the way it's supposed to, because again, that smooth, glistening cartilage that we're supposed to have is no longer smooth and glistening. It's got potholes all over it. It looks like a little rat's been chewing on it. And when that happens, it's tough to function. And we'll talk again as we get into this. You can treat gout, or you can treat any of these osteoarthritic symptoms with conservative treatment. It's not going to reverse the arthritic situation, but what it is going to do, it is going to create a situation where we can do corticosteroids, like the little cortisone injections, to help calm down the inflammation. And that's something we often do in an acute gout inflammation, where the foot's red hot and swollen. We'll actually put a needle in there and put some steroid in there to try to calm it down. That will also diminish the inflammation of the joint, and it will create a situation where you're more comfortable. It's not going to cure the gout, it's not going to cure the arthritis, but it is going to make you more comfortable and able to do the activities you want to do. We can offload and supplement those with orthotic supports. These are things that you put inside your shoes that are molded specifically to your feet that can help, again, protect your footing and make it more comfortable to ambulate. That does not reverse what you have. Unfortunately, this does not reverse it at all. But again, these are things that we can do palliatively to help allow for it to be much more comfortable. So when you think about shoe gear, shoe gear is something important that you have to, when you have an arthritic foot or ankle, you've got to really match your shoes. And sometimes this is trial and error. This is something that is, very, very challenging to find. You may find that you waste 2 or 3 pairs of shoes because you're not able to, do the activities that you want to do in those particular shoes. And when things like that fail, then there are some surgical treatments that we can go through and do. The most common one is a joint cleanup, where we just go in and remove the spurs. It's called a chylectomy, which is a Latin term that means joint cleanup, so to speak, and it is something that allows you to try to restore that motion for a period of time and help basically clean up the joint. When all else fails, then we can go and we can actually lock that joint up, and we can make the toe into the position we need it to be in, and we can utilize a combination of screws and things like such that you see in the picture here on the left, and that will allow the toe to function without grinding anymore. Those are things that are very, very common, and they're very, very successful. Pele played 70% of his entire soccer career professionally with a fused great toe joint because of the arthritis he had. And because of that, he was able to propulse off that foot in his soccer cleats and not have any pain. You may hear of some docs talking about implants and distractions of the toe and things like that. These are techniques that are not as reliable. These are techniques that we don't do, or I don't do here at Coordinated Health. These are things that the research has been less substantiated and things of that nature, but you may read and hear about things like that, and they are out there, and they're certainly open for discussion, but it's not something that we typically employ in our practice too much. The midfoot is really where the metatarsal bones and the hindfoot come together in this region right here, just in front of the ankle. And one of the most common pathologies that we see in the arthritic foot situation is something called the adult acquired flatfoot. And if you've had an older family member, or somebody had said maybe something to you called fallen arches, this is what many times people in the 20s and 30s and 40s talked about when they had fallen arches. Meaning, one day my foot looked good. I had a nice, even if my foot was flat, I had a nice arch that was still maintained. And then one day I looked down, and all of a sudden my foot had flattened out and kind of rolled in, and my arch had fallen. Well, what that is a condition where the tendon of the foot and ankle, called the posterior tibial tendon, starts to attenuate and fail. It stretches out. It loses its mechanical advantage. And when that happens, you'll see that the heel will turn out, the inner arch will roll in, and if you were to look at somebody from behind, you'll see that their toes are sticking out to the outside of their foot. We call it a too many toe sign, very scientific there. But what that shows us is that tendon that goes to the inside of the ankle is no longer able to support the arch anymore, and when that happens, the arch falls, the foot and the ankle tend to rotate in and out, and it creates a situation where the foot is much more pronated. And again, pronation is when the foot rolls in. And that pronated state is something that over time can become very arthritic, and it tends to affect the midfoot and hindfoot significantly. And when we think about that adult acquired flatfoot, we have to think about what kind of stage that is. So, and I'm not going to go through the stages that in depth, but the point to my story here is that the earlier we treat this, the more reliable the treatment and the better off it is for you. If you can treat that tendon when it's only been stretched out a little bit before it has really started to tear, it's a heck of a lot easier to treat. We can get you in with a therapist to strengthen the tendon complex. We can get an orthotic or match a shoe to you properly to help control that foot, and we can help try to cut it off at the pass. But when it advances into a stage 2 or a stage 3 situation where this tendon starts to tear a little bit, the foot becomes a little bit more rigid, our options as physicians become much more surgical than they do when we treat it. And that's certainly very intuitive, but it's something that if you do start to feel like you have some burning pain on the inside of your ankle or your foot structure is starting to change, it's worth not putting off. It's worth going ahead and getting that MRI so we can evaluate the tendon. It's worth getting a good exam so we can look at your orthopedic structure, and that way we can go ahead and we can say we can do X, Y, and Z to try to cut this off at the pass, because this can become very, very debilitating. My father, who's 62 years old and still runs 10 miles a day, has a left foot which looks like it's from this planet because it is so pronated and so rigid, and he's so darn stubborn he doesn't want to do anything about it. But again, when he gets up out of bed, it takes him 20 minutes just to get ready to go run because he can't walk. And once he gets going, he's got to go all day because the minute he stops, it's hard. And it's because of that arthritic foot and ankle situation that he's developed because this tendon ultimately failed. And again, the two names for this condition are called the adult flatfoot, because you had a foot that was good when you were younger, but as you get into the adult situation, it becomes much more flatter, or the posterior tibial tendon dysfunction. And that posterior tibial tendon is that tendon that fails us to create this type of situation. Sure.
You're just working on one of the treatments. I'm not sure if I'm going to say it like that.
Calcaneal slide. What that is in a situation where sometimes in an early grade 3 or stage 2 adult acquired flatfoot where the foot is starting to roll in a little bit, but the tendon is still viable, we can do some things to augment the tendon. Sometimes we take a tendon behind it and move it over to the other tendon and help support it, give it double the strength. And then what we'll do is make a small cut in the heel and actually take the heel that's facing that way and slide it over so it's centered back underneath our leg again. And it sounds a lot worse than it really is. It's actually a very moderate way to correct a foot that is starting to go adrift on us. So basically we're able to realign that heel and put it back so it's centered underneath our extremities again.
Do people that have flat feet and Spurs, which in my case I have,
Sure.
do they have less of a problem if they live with them?
No, not necessarily. Certainly, I would say that people that actually have flatter feet tend to get this a little bit more because your tendon is under stress that much longer, that many more years. So, you tend to see this more in people that have a more pronated foot type or a flatter foot. Kind of have a wider foot with a decreased arch and a heel that already goes out, because over the years that will put a lot more stress on that tendon. So these are things that again, when we think about it, this is a tendon problem that again leads to that arthritic situation if not managed properly. So it's just another way where you don't necessarily have to have a traumatic event. You don't necessarily have to have something happen to your foot and ankle for this to happen. This is something because we inherently have the situation where the tendon can fail. And there's some neat literature that has come out over the last maybe 12 to 24 months where they're actually looking at familial history of the posterior tibial tendon, saying, okay, do you have a genetic predisposition to having this tendon fail? And what we're finding is that the tendon will fail up here at the calf muscle. The muscle actually stretches itself out, and that's why the tendon starts to give. And it's because of a lot of hereditary factors that we've got going for us. So, and in the most severe situation, we can do a procedure like this where we basically have to put the foot and the ankle back together, the hind foot back together, and we lock it into place. But what it does is it restores the arch, and it gives a situation where you've got a nice a nice longitudinal arch there, and the patient can weight bear, but it's a bearable procedure, and it's a 12-month commitment. So we try to encourage all of our patients to seek early treatment so that it doesn't have to get to that situation. And the last segment that I'm going to talk just a little bit about before Dr. Rudolph talks is finally ankle arthritis. And ankle arthritis is, again, that situation where you see here on the left. The most common reason we see it in our practice is that broken ankle. The joints have been fractured. The cartilage is misaligned. You can see the break there, the break there. The bone is rotated, and all of this cartilage, when that shear injury occurs, when the patient slips on ice up here in the Poconos in the winter and the ankle goes out from under them, that shear creates a permanent damage. And no matter how well Dr. Rudolph or myself puts the joint back together, that cartilage has been affected. And you know, for Brian, it may be very, very different than it may be for you guys. You know, he may get arthritis in 6 months. He may not get arthritis at all. You know, you may get arthritis in 15 years. There's no rhyme or reason. What we have to look at is your familial history to the predisposition that you're going to have to getting arthritis, and there's no way that we can, really test for that. Certainly, the more severe the injury, the more severe chance, or the better the chance you have of getting a significant arthritis. And when you have an ankle that is arthritic, again, that joint space narrows. The ankle is unable to go up and down like it's supposed to. You're unable to push off your foot and ankle the way you're supposed to. And it will often affect, we typically talk, when you lose your range of motion in one joint, we'll typically talk the joint above that. In this case, that would be the knee, and the joint immediately below that, in this case, would be the midfoot, take a significant amount of strain. So we'll often find that those patients will often have, midfoot pain. They'll often have knee pain. It really affects your entire body globally. And when we think about our joint, you can take a look at the fracture that we had before. You see that joint space. On this patient, you can barely see the joint at all. And you can see how it's brighter here. That's called sclerosis. That's where the joint has just basically grind over the years. It creates a situation where that joint is unable to glide the way it's supposed to. And that happens, again, in any joint of the body, but when it affects the ankle, you're unable to do those necessary things you need to do to ambulate properly. When we treat arthritis, again, it's broken down into stage 1, which is mild, stage 2, moderate, and stage 3, severe. Stage 1, we can treat, again, with anti-inflammatories. We can treat with orthotics. We can treat with physical therapy. We can treat with, cortisone injections. And sometimes we can even treat them with an off-label use of something called hyaluronic acid, which you may have had friends and family get that in their knee. These little kind of visco fluid injections that often derive from chicken and, chicken feed and things of that nature that we can put into the joint to try to create a healthier environment. It's not on label for the foot and ankle, but it is something that some patients are willing to try and pay for, and we've had some moderate success with it. In stage 2 arthritis, sometimes that can get a little bit more aggressive, where we have to go in with a camera and clean it out. We try to take a look, see exactly how bad it is, try to remove any inflamed soft tissue. Again, we can kind of blend this with some of the same things we're doing in stage 1: physical therapy, range of motion, stretching, anti-inflammatories. In some cases, we'll even utilize braces. And there are many, many, many different types of braces. Some of them are bigger than others. Some of them are more functional than others. It all depends on what the patient's needs are. And then ultimately, when that patient goes on and becomes a stage 3 situation, where we've basically have no joint space left, we're bone on bone, the patient has exhausted their entire conservative care, we then need to go and do something a little bit more aggressive. And that's when we either do something called an ankle fusion or an ankle replacement. And I'm not going to spend a whole lot of time on either of these, but the ankle fusion is something where we basically, just like we do in the big toe joint, we lock that joint up. And you can see here, this joint has been fused. And we do that in a position where the foot can then push off, it doesn't grind, and allows the patient to weight bear and do its activity as much as possible. It's a big time commitment. It is something that we typically tell our patients they need to devote a year of getting better for this to happen. But when they get better, they do very, very well. We've actually have some people that work here. We have a nurse that works here that has an ankle fusion. I guarantee you wouldn't be able to pick her out from any of the other people walking around here. Patients can walk very, very well. The other situation, which is somewhat newer in terms of technology, is an ankle replacement, where we'll go in and actually replace, just like we do in a knee or a hip, we'll actually replace the joint that's not functioning, and we use a metal component in the tibia. We use a metal component in the talus, which is the main ankle bone. And that clear area in the middle has a plastic shock-absorbing spacer. It's called a polyethylene implant, which allows the ankle to function. You're able to have your range of motion. You're able to use it a little bit more functionally. But again, the patients that this qualifies for, or the patients that qualify for this treatment, are a little bit more strict than that of a fusion. We have to assess the amount of curvature in the leg and ankle. We have to assess the quality of the bone, and we have to look at the way you use your body and the activities that you're doing before we can, consider this an option for you. But again, the treatment for arthritis, the main key is getting it early. Being aggressive with the early treatment, doing the things you need to do to keep the joints loose and functional. And if you do that, we can manage it pretty well. So that's my spiel. I think Dr. Rudolph's up next. Any other questions we have? What we'll do is when we're all done, we'll go through it as we're doing our screenings. Thank you, guys.
Good morning. My name is Jason Rudolph. I'm an orthopedic surgeon. I specialize in foot and ankle surgery. I also do a lot of sports medicine surgery. I do quite a bit of trauma surgery. I do some hand stuff. I don't do any back surgery, but I do have a real niche specialty in foot and ankle surgery and trauma. Although I'm new to coordinated health practice, I have been practicing in the Lehigh Valley for the past 12 years. I've been down in Bethlehem and Easton and Phillipsburg, and recently now that we're part of coordinated health, I've been coming up here to Broad Edgeville and hopefully coming up to this East Stroudsburg area a little bit as well. So I'm a board certified orthopedic surgeon. I do live locally, and I've always felt the policy I treat my patients like friends and neighbors. I did play college football, so I've suffered just about all the orthopedic injuries you can suffer, and therefore I know what it's like to be a patient as well as an athlete trying to get back. Next. So what is an orthopedic surgeon? Just quickly, college for 4 years. I went to Princeton. Medical school, another 4 years. I was in Chicago. Did an orthopedic surgery residency, which was 5 years. That was done in Monmouth Medical Center in New Jersey. Then I did a fellowship in foot and ankle surgery and trauma surgery down at Vanderbilt University. So in general, I essentially graduated from 26th grade before I even got my first paycheck. Next, please. So I'm going to try to paint a few broad strokes in foot and ankle. Dr. Brigido did a great job of localizing right down to osteoarthritis, but I'm going to try to paint some broad strokes and kind of go through some of the myths that are out there in foot and ankle. So myth 1, high-heeled shoes cause bunions. Not true. Bunions are inherited. Take a look at your mom, your dad, your grandparents, what their feet look like, pretty much what your feet are going to look like. People who have never worn shoes their entire life, who live in the islands of West Indies, can have bunions. However, the myth is that pointed shoes can cause bunions. Not true. If you put on a narrow pointed shoe, it's going to make your bunion hurt. Of course, if you bind your feet together like they did in ancient China, 24 hours a day, 7 days a week, yeah, that'll work, but most people don't bind their feet in high-heeled shoes 24 hours a day. Next one, please. So if you take a normal foot and you try to cram it into some of these pointed shoes, it's going to hurt. If you cram your bunion into these pointed shoes, it's going to hurt. Next picture, please. This is an x-ray of somebody wearing a high-heeled shoe, and you can see our foot is just not designed to be stuffed into these pointed, fashionable shoes, but if you do it, you can do it, but it's not going to give you a bunion. But if you have a bunion, it's certainly going to make it more symptomatic. Next picture, please. So myth number 2, are ankle sprains worse than a broken bone? So first of all, let's evaluate that. What's a sprain mean? A sprain is an inversion injury, fancy doctor term for when you turn your ankle. That's the most common sprain. And in general, what happens is the ligaments that are connecting the bones together, in this case the fibula, which is the small bone on the outside of your ankle that everybody can feel, connects to the ankle bone, which is called the talus. Those ligaments stretch. That's the most common type of sprain where you turn your ankle in. Rarely do these ligaments ever tear in half. It's almost never. Maybe with a huge car accident or something, it's possible. Next page, please. So this is the busiest slide, and don't take notes on this slide, but we basically grade sprains. Like everything in medicine, we have to break it down. So grade 1 is the simple sprain, turn your ankle, sort of strain the ligaments a little bit. A couple days later, you're walking normally again. Grade 2, probably the most common one, playing a sport, get tackled, roll the ankle, swells up, can barely walk on the first day, kind of gets a little bit better the next day, and of course, with each of these grades, the ligaments stretch or tear is a little bit more significant. Grade 3 is the most severe. You really have a turn to the ankle, maybe in a car accident. At this point, the ligaments are actually stretched out so much that by an MRI scan, you can see that they're actually torn. Again, these ligaments don't get snapped in half. They're not like rubber bands. They just stretch out almost like cellophane or plastic can. Next picture, please. So just your one anatomic picture I'll show you here. Fibula, small bone, tibia, big bone, and then these are these ligaments. And in these pictures, they always look, like they're regular little bands like that. And in actuality, these are just thickening of the lining of your joint. So those are the main two ligaments that I was describing. Next picture, please. So how do you treat ankle sprains? Classic, RICE. Anybody who's taken a first aid course knows RICE. Rest, ice it, compress it, and elevate it. So compression, usually we're talking an ACE bandage. Of course, you don't put it on too tight, and elevating is pretty obvious, equal or higher than your heart. Bracing is something that we do a lot. If anybody in the entire eastern seaboard has ever gone to an emergency room with a sprained ankle, you always leave with an air cast. You come to my office, I throw the air cast out because it's hot and sticky and doesn't really work so well. We have other sports braces that we use all the time that really give you good support and get you back to life. Physical therapy, this is the key, and that's what this whole section here is dedicated to. Most people with bad enough sprains that they come to see us, the best way to get you back to life and to sports is through physical therapy. Not only do you retrain the muscles, you get the ankle moving again, you get the muscles strong again. We also retrain the nerves so that when you do hit a pebble, your nerves is working again so it doesn't roll and we get you back to life. 85% of the time, those simple things work for the bad sprains. 15% of the time or so, sometimes we need to talk surgery. No reason to get into the details of these surgeries, but in general, the worst of the sprains and the worst people that don't do better from those sprains, sometimes we do have to go in with an arthroscope like Dr. Brigido noted, and sometimes we have to tighten up the ligaments. But in general, if you sprain your ankle, usually you're going to get one of these top three things and you do just fine. Next, please. Ankle fractures. Well, those are so variable that we could spend a whole 3-day seminar talking about different kinds of ankle fractures. But in general, bone heals very well. It may require surgery on occasion if those bones are shifted out of position and we need to put them back in position. So when you're questioning whether is it better to have a break or a sprain, well, it all depends on which bones are fractured, how stable is the fracture, does it need surgery for me to put it back together, and does it involve the joint? Because like Dr. Brigido has talked about ankle sprains, ankle arthritis mentioned, if the fracture goes into the joint, that raises our level 100-fold because now all of a sudden, not only are we going to have the bone heal together perfectly, which is pretty easy to do, but now your cartilage with that magic Teflon coating at the ends of your joints has to magically fuse together too. And if that doesn't happen, well then you're talking those big surgeries he was just discussing. So, in general, next picture please. Here's a little guy, turned his ankle and can barely even see it because there's a little light here, but he has this teeny little fleck right there. Not a bad sprain, not a bad fracture, and I'll take that one. Next picture. Here's a poor guy that fell out of a tree stand, crawled 3 miles out of the woods, and he ended up with a plate that goes from his ankle halfway up his leg. So that one I don't want. Next picture, please. So in general, the majority of time sprains can be treated conservatively. Very rarely do they require surgery. The majority of fractures heal very, very well, and many of them require surgery. So in general, sprain, break, I'll take the sprain. Next picture, please. Okay, so the third myth. I have heel pain. I must have a spur. Well, heel pain can have many, many, many problems, and the majority of the time in our foot and ankle practice, what you're going to see is something that has to do with the heel. And the heel pain can have all sorts of different causes. I wrote down the top 4 here. Plantar fasciitis. This is the one by far, if you are seeing people in the office, this is something you're going to see regularly. This is the classic, the heel hurts worse in the morning when I first get up. I can walk a few steps, it stretches out, it feels good. Until I sit down for lunch, I sit down for my lunch break, try to stand up, and my heel's killing me. And everybody thinks that's a heel spur. We'll get into that next. Achilles tendonitis. So the Achilles is the big tendon in the back of your ankle. Everybody has one, everybody can feel it. And that's a different spot that you can have some heel pain. Bursitis. This is sort of pain directly on the bottom of your foot. It's there all the time. If you're a barefoot person, and I know there's a lot of barefooter people out there, that's one of the things you can get. Stress fractures. Again, stress fractures we can see anywhere. You can see it in the heel bone. Another thing that can cause pain in the bottom of your foot. To quickly touch on a stress fracture, I always describe it as a paper clip. You take a paper clip and you bend it, it gets a little hot. You keep bending it, you get those little cracks in it. That's a stress fracture. If you keep bending even more, it can break in half, and that's when you start to see things on x-rays. Next picture, please. So, plantar fasciitis. Like I said, this is the most common heel pain that we'll see in the office. The plantar fascia, it's not a ligament, it's not a tendon, it's sort of a thickened lining on the bottom of your foot. It goes from your heel all the way out to your toes. If you've had plantar fasciitis, you know what I'm talking about. It hurts when you first wake up in the morning, stretches out as the day goes on. It's, like I mentioned, extremely common, worse in the morning or after you sit for a period of time. Usually, we can't really tell what the cause is. It has a million different causes. Some people gain weight, some people lose weight, some people take up a new activity, some people we just don't even know why it happens. This problem, although it's extremely common, the good news is it very, very, very rarely requires surgery. Most of the time stretching, again, physical therapy, and orthotics help out a lot to help stretch out that band of tissue on the bottom of your foot. Surgery, you have to have the symptoms for 6 months to a year. You have to have gone through a whole slew of different treatments before we ever discuss surgery for it. Next picture, please. Insertional Achilles tendonitis. Now, this is the pain directly in the back of your heel. Sometimes, again, it can be related to an injury. Sometimes it can be related to overuse. And most of the time, we don't know what causes it. It can happen in athletes. It can happen in non-athletes. Some folks, when we do an x-ray, you can actually see a large calcification, which means, again, like sort of a bone spur that's growing up in the back of your heel, digs right into that Achilles tendon, causes these little tiny tears, and that can cause pain. Those are the folks that, if you aren't getting better through therapy, sometimes that requires surgery to kind of take the tendon off, clean it out, get rid of all those bone spurs. Next picture, please. So that's what I just mentioned here. As far as treatment for Achilles tendonitis, it's most of the time non-operative, stretching, bracing. And I just mentioned this as sort of a public service announcement. Never, ever, ever let anybody put a steroid shot near your Achilles tendon at the bottom. I've seen a couple of folks in the last few years where that happened. A day later, the whole tendon tears off. It's just too inflamed. It's too sore of a spot. So you can have shots in different places in your heel, but I just warn you, avoid getting a shot right where your Achilles tendon inserts. Next spot, please. So, to answer the question, you certainly can have a heel pain without a spur. You can have a spur and you may not have any pain. And for only certain conditions, and particularly what I'm talking here is usually that Achilles tendon problem, do we ever have to actually remove the spur? So hopefully that answers that myth. Next one, please. So it's not great light in here, but this is the heel, and you can sort of feel this big spur in the back of the heel here. And if it was a little darker, you could see this spur actually goes all the way up into the Achilles. Next picture, please. And this is the picture afterwards. I don't know if you can see that back there, but I've now removed that spur as well as some of the bone back here. And that's the only occasion that I'll remove, let's say, spurs from the heel. Next picture. So the last myth I wanted to mention, everybody worries that foot and ankle surgery hurts more than any other surgery we do. And like I said, I do more than just foot and ankle, but a lot of my surgery is foot and ankle surgery. And that certainly may have been the truth in the past, but we have so many techniques we use now to prevent that post-operative pain. Nerve blocks are key. The facilities that Coordinated Health has have fantastic anesthesiologists, and these guys are really expert in giving a block ahead of time. What that means is we essentially are numbing up your leg and your foot and your ankle before you even get into the operating room. Sort of tricks your body into thinking nothing happens. So a lot of those triggers that start the pain don't ever occur because your foot's numb before you ever have surgery. That's the key. Other things we talk about, not only just putting you on a painkiller, but we use a lot of anti-inflammatories. We teach you a lot of techniques about elevation, things like that. So in general, if it comes to a point where unfortunately foot and ankle surgery is something you're going to have to consider, I really don't want you to think that, it's going to hurt so much that there's no way I'm going to put myself through it. In fact, I do shoulder surgeries, and I'll tell you, shoulder surgeries seem to hurt much worse than any foot and ankle surgeries does, mostly because we can use a lot of these techniques now. So that's the end of my talk. Thank you.